look at the dry bones, let's see how they look in the living body. The big gap between the sacrum and the ischium is bridged by two massive ligaments. The sacrospinous ligament goes to the ischial spine. The sacrotuberous ligament goes to the ischial tuberosity. Let's go round to the front and see those two ligaments from the inside. Here's the sacrospinous ligament. Here's the sacrotuberous ligament. These two openings are the lesser sciatic foramen and the greater sciatic foramen. The sciatic nerve passes through the greater sciatic foramen. The obturator.
I'll repeat this part again because this one is
greater sciatic foramen. The obturator foramen. These two openings are the lesser sciatic foramen and the greater sciatic foramen. The sciatic nerve passes through the greater sciatic foramen.
Certain time we have a sciatic nerves compressed is due to any kind of pain and problem. So once your sciatic nerve pass through this, by reason or without any reason, if your muscular contraction is there, without bending forward or bending backwards, you can feel the compression to your sciatic nerves. Okay, and again, sciatic nerves passes through. If you has a contraction onto your pelvis through any poses, it doesn't need to be necessarily to do yoga. A healthy body who just go to the office, drive the car and do a little bit homework, don't feel any sciatic pain. Once they come to do yoga, if they do some kind of poses, after that they realize they have some pains and numbness. It's not due to they have yoga become injured them. It's the physical body they have it which causing the injury by contracting the pelvis. Any contraction they do into the pelvis which can compress the sciatic nerves, because sciatic nerves, once I show you the muscles later on, next day you will see that where from the sciatic nerve being passes through, and through any kind of contraction into your pelvis you may feel, and sciatic nerves again are not exactly same for every one of us that passes through. It could be some exceptional. This is surprise to people that hey, how can be my sciatic nerve passes through from a different part of my muscles compared to my friends. This also can be happened.
The obturator foramen is largely closed by the obturator membrane. The obturator nerve and vessels pass through a small tunnel here. Now let's take a look at the hip joint. We'll remove the femur for a moment and look at the acetabulum.
See how good it looks our hips.
Here's the broad C-shaped articular surface, sometimes called the lunate surface. This non-articular part of the acetabulum is the acetabular fossa.
So fossa doesn't mean that it have to be on the top of the muscles holding. The fascia also can be into your ligaments, into your tendons, which is holding tightly. The ligaments, fascias are much more stronger and tighter. Okay. When you see the dry bones, look so beautiful. When you see with the dissection bones, it looks a little more beautiful, right?
Edge of the bony acetabulum, this rim of fibrocartilage, the acetabular labrum, adds to the depth of the acetabulum. This is the cut end of the ligament at the head of the femur. Its other end,
and that's the part of it. That's the part which holding this ligament, holding our hip socket. Can you bring him up? That's the part is holding, that ligament is the most tight and strongest ligament holding with our acetabulum to our head of the femur. This is the ligaments.
This rim of fibrocartilage, the acetabular labrum, adds to the depth of the acetabulum. This is the cut end of the ligament.
And this cartilage can be tear also. Certain time, certain movement, certain compression, certain extension, certain kind of traction, too much push, this also can be done. Any problem happens inside the body, they not have any standard problem because of this, because of that. Always is very subjective, very subjective. It's just like a researcher, you know. Everybody drive the car, but those who car mechanic, they know the same problem but different reason. Same in our physical body. Any problem happen, there's no, it's very subjective based on the age, based on the body type, bone type, muscles type. then your practice, your nature, what you want, based on all this other inter-physical body injury happens. So do not jump into a conclusion, because of this happened, because of that happened. No. There's not even single one reason for any problem to be happen. You really need to make it maximum factor. What I do when I hear anyone has a problem, let's say Sumit come and saying I got this problem, I'll be asking at least 15 to 20 questions, and all the questions are different segment, different areas, and I'll make him do something not related to the posture. If he say he got a back pain, hip pain, I'll make him do raise hands and do a cow face pose. And I'll push into his shoulder, I'll check it out his endurance level first. If before I push he say, pain already, then I know, okay, it's over here got 70% problem, physical 30% problem. So you know, test different factors of human body. When you're going to cure them is not only the body, because you're not doctor. You're not going to cut them and paste them. You're going to heal them, right? For healing is the person going to do, not you going to do. Is you need to find a method to heal the person. So when you find a method to heal the person, you're not a doctor that give anesthesia, cut the body and paste it and let it go. So you are a person who is going to heal the physical body, the joints and the ligaments. You need to understand the physical body very well. Once you do not understand the mind and the body and the limitation and the strength, it will be very hard for you to do. You may further injure the person. Okay?
The head of the femur. Its other end is attached here on the center of the femoral head.
Interesting, right?
Yeah.
Yeah. Again? Okay.
Above the acetabulum, this rim of fibrocartilage, the acetabular labrum, adds to the depth of the acetabulum. This is the cut end of the ligament of the head of the femur. Its other end is attached here on the center of the femoral head. Now let's go back to the intact hip joint.
When you call about hip replacement, those who cannot squat, the olden age, they cannot move. What exactly happened? The rotation is, there's no more space for rotation, lock and tight. The ligaments are shortened and tightened so much that the ligament doesn't give space. Due to the ligament doesn't have the space, the hip is not rotating anymore. What they do, they cut it from here, the ligaments, and they will be add on a plastic fiber. They'll be cut from the neck. This part will be cut it out. In hip surgery, you always cut it off this part, detach it, and a plastic will be go into the bones here, and this plastic will be attached with acetabular, and that's the legs can move. Those old people, their move is small on the legs. Why? Because the range of motion in the joints is not big, because the ligaments which is connected from the head of the femur to the acetabular are shortened because they never been stretched. With the upgrade of technology, we doesn't need to squat anymore. You know, that's the main reason. Olden days, have you asked our father, grandfather that anybody have replacement of the hips? Nobody have. Because every morning they have to squat. They have to be flexible. From the ankle, knees and the hips, they got no choice.
The capsule of the hip joint is a sleeve of ligaments. The capsule is thin on the underside. Everywhere else, it's thick and very strong.
What you see here, you can't see inside anything, actually. Okay? What you see outside, this is all covered with the ligaments. All the ligaments and muscles are being covered inside, you can't see anything. So when you see a skeleton and when you see a real bodies are very different, very different. It's even a doctors, those who go, they can't see that body anymore until they scrub all the muscles and the ligaments, take it out, and then they may see the bare bone. Otherwise, they're not able to see. And this is what you see is only the ligaments, the muscles is not here.
This part of the capsule behind is called the ischiofemoral ligament. This anterior part of the capsule, which is the thickest, is known as the iliofemoral ligament.
When it's moved, how it's moved.
The fibers of these capsular ligaments become tight and the joint is extended. The capsule is attached to the hip bone.
I want to bring it back to let you see again. Over here. When the hips move, how the ligament moves.
Is called the ischiofemoral ligament. This anterior part of the capsule, which is the thickest, is known as the iliofemoral ligament. The fibers of these capsular ligaments become tight when the joint is extended. The capsule is attached to the hip bone all the way around the acetabular labrum. On the back of the femur, the capsule is attached partway along the femoral neck. on the front of the femur, the capsule is attached out here on the intertrochanteric line. Now let's take a look at the various different movements that occur at the hip joint. Movement can occur in 3 different axes. Forward movement is flexion.
Flexion, extension.
Backward movement is extension. Movement out to the side is abduction.
Abduction.
Movement toward or across the midline is adduction.
Abduction.
Lastly, rotation. Rotation outward is lateral rotation.
Rotation.
Rotation inward is medial rotation.
Okay, I'm going to stop here. We're going to stand and we're going to practice this. Okay? Because you guys need to know stand. Stand. Do the action and remember this.